All right. So today I wanted to talk about a topic that is near and dear to my heart, and that is how to make cool slides. I guess the formal title can be how to utilize animations to help improve your academic presentations. And notice that I didn't say my topic is how to give a good presentation because it will be ironically bad if I end up giving a really bad presentation on how to give a good presentation. But I do like making pretty slides, and a few of you have actually approached me and asked me how I made some of my slides. So hopefully this helps some of you who would like to get some practical tips and tricks you can use on your future academic presentations. So just a couple remarks and disclaimers here. First of all, I found out that these PowerPoint animations and transitions don't show up at all on WebEx. And that is the reason why we're using YouTube today. And I was devastated initially because I've been wanting to talk about this for a long time. And I was more than halfway through making this PowerPoint when I found out about WebEx. But then I found out about YouTube. So thank you for your patience and technical difficulties. Again, please mute your WebEx and just continue listening to the presentation on YouTube. Also, I will upload this PowerPoint so that anyone can take a look at the actual commands and sequences behind what you will see today. And also feel free to copy stuff from this PowerPoint onto your future presentations because we all need a place to start. And I don't mind sharing at all if everyone's PowerPoint could look a little more beautiful. So another thing, almost all of the visuals I used in this presentation was from Google. So besides the aesthetics, the name of the game for visual aids is to fight for audience's attention. Especially in this day and age when you can just check your Instagram or Twitter or whatever else literally in the matter of seconds. I think it's um, I think it's really hard for the presenters to fight against the audience's temptation and for distraction and actually win their attention for the duration of their presentations. Now, it would be a different story if you actually didn't want the audience to pay attention to your presentation. I know we've all been there, but that's besides the point. And of course, the other purpose of visual aids is to help get your point across more effectively. And another disclaimer here, some of the things I will show you today will take a very long time to make. So if you want to do some fancy animation for your PowerPoint, it does take time and patience. And ultimately, you have to care a lot about your presentation. And fortunately, I think that applies to a lot of scientific presentations for big meetings, because if you don't care about your own presentations, nobody else will, right? They're all there to present their own stuff. But some presentations just grab your attention either because of the sheer force of the subject matter or because an average subject matter was expertly presented. And you don't always have control over how objectively interesting your topic is, but for the most part, you have control over how it's presented. So I'll start with how to make an attention-grabbing title slide. I was actually introduced to this idea during research. There was a lab manager lady who would give us talks about how to improve our presentations at national meetings. And her stand on the title slide was, don't put any text, period. Just no text, single picture, full screen, and that's it. No name or title, date, or anything. Her reasoning was most of the time, people will know who you are, either because they already know you, or they have a program to look up my name and the title of my project. And since then, I've kind of adapted the idea. I couldn't completely get rid of the text or putting my name there or the title, but I try to put attention-grabbing picture as a full screen. Remember, the battle for the audience's attention begins on slide 1. So I'll go through this using some examples. So this is Chris's M&M slide from last week. Thank you, Chris, for letting me use your slides. And it's pretty good, minimalistic and to the point. But when he was giving the presentation, and I saw one of the CT scans, and I was thinking, how would it look? Would this be more interesting? I mean, when I make the slide, your eyes immediately go to the picture before reading the text, right? And you're thinking, what is that big Goomba? And what happened to this person? It makes you question. It's a very impressive CT scan. So put it up there right up front and, make the audience wonder. It grabs their attention. How about this one? I dug up this relic from the past. It's from my research day presentation in 2014 when I was at PGY2. And it's a pretty standard title slide, right? Decently big fonts, similar color tones, credits and everything. But what if it looked like this, though? What do you think? You can see the esophagus getting repaired. You can see the lung tissue at the bottom oscillating from the jet ventilation, able to give good exposure for the repair. Did that make you care more about my research a little more than the previous slide? The purpose of the title slide is to grab the audiences from the get-go. And a lot of good title slides is about thinking outside of the box, I think. It's okay to use images on a title slide. It's okay to put a video in the title slide. If you want to use the video again later in your presentation, go ahead, use it again. Repetition is good, and picture is worth 1,000 words. So, how about this? Minimalistic and to the point, right? But you have no idea what I'm going to talk about. Some dude named Nick from Albany did some research. Well, I guess now you do. Okay. All right, I think we are back online. Okay, let me know if you hear me talking and see the screen. All right, I think we are back online. Please type in the chat window if you can hear me and see my slide. Okay, all right, so I will keep going. Sorry about the hiccup. So I was going to say, sometimes you can use a little humor. This was my title slide from colorectal conference in August. I know Dr. Valerian liked this one because I remember him actually commenting that it's a good picture. Now, you can't always find interesting title slides, right? And sometimes I use gimmick like this to at least set up the mood for the audience participation. This was for a visiting professor case presentation. And I couldn't really think of anything cool to put on the first slide. So instead of my name and some big font that says case presentation, I put this up as an icebreaker. And the audience could participate in creating this word cloud. Plus, it is a good way to test to see if your polling software works, because I used the audience participation throughout the presentation. And also for journal club, sometimes you just have to take the easy way out. But the next time you make a presentation, especially the ones you give at big national meetings, try experimenting with the title slide to grab some attention immediately. So let's get to the animations part. I think when used right, they can really help you to highlight different points and even simplify complex concepts for the audience. And even if you don't want to use any animations, I'm a firm believer that fewer words you have on the slide, the better your slide is. And I think this is the biggest takeaway from my presentation today. And the reason is if you have a lot of words on the slide, the audience just automatically starts to read, right? And that automatically creates a conflict between their reading voice and your speaking voice. So if you have more visuals and fewer words, that's like telling the audience, here, why don't you focus on enjoying the scenery? I'll provide the audio tour guide. So this is my slide for a journal club presentation back in November, I think. And this is my first slide, you know, the one where I talk about the background for the study and everything. And my content was this. So ischemic colitis is a well-known devastating complication of a AAA repair with mortality in the ranges of 50 to 60%. The overall incidence of ischemic colitis after AAA repair is relatively low at about 3%. But with emergent or ruptured AAA repair, the reported rate goes as high as 30%. Before I go any further, let me show you what this slide could have looked like. It could have looked like this. It would have been a lot easier, actually, for me to just do this. Just type up the information I want to get across and call it a day. But if I cut down the words just a little bit and put a picture of a AAA repair, it can look a little better. In fact, I think most of our academic presentation slides probably look something like this. But what if we could go a step further? Maybe get rid of all the text, because you're going to say them anyway, and find a way to graphically represent the numbers. It could look like this. And then you can just say the same thing. Ischemic colitis is a devastating complication of a AAA repair. Mortality ranges between 50 to 67%. The overall incidence is pretty low at 3%, but goes up to 30% for emergent cases. So less text, more graphics is one principle I definitely try to apply to any and every presentation I have to give. And next, I'll start showing you some simple animation tricks you can use right away to improve both the aesthetics and effectiveness of your presentation. So the first thing I want to tell you is wipe. This is probably one of the animations that I use the most. So I'll show you how I utilize it. So draw a simple box. And when you right click on it, you can go to animations. And if you choose wipe, it should have this effect. So when you go to presentation mode, the box won't show up until you click. Now you can change the direction of the wiping by going to effect options, and you can choose whatever direction you want. As you can see, wipe down, wipe to the right. Now let's apply, and you can apply this to various different shapes like lines, boxes, and colors. And I'll show you how I apply this in real life. So you can apply this to the text. 35-year-old female is referred to you for the evaluation of pancreatic lesion found on a CT scan after trauma. And if you just simply use wipe command for colors or lines or boxes, you can just put them on top of the text and make it look like somebody is highlighting your text on the slide. So this is part of the presentation I gave while I was on G1. And it was a presentation on how to distinguish pancreatic cystic lesions for the ABSITE. So I'll read the question, and I want you to either remember your answer or write it down somewhere, because we're going to go through the answers later. So a 35-year-old female is referred to you for the evaluation of a pancreatic cystic lesion or pancreatic lesion found on a CT scan after trauma. She is a non-smoker and a social drinker. The lesion does not appear to have a direct communication with the pancreatic duct. Percutaneous aspiration of the cystic structure is performed. Analysis of the fluid shows a low-level amylase and carcinoembryogenic antigen, CEA level of 0.35, normal is less than 3. What is the most likely diagnosis of this cystic mass? So I'll give you a couple seconds to think. Either remember the answer or think about it. All right, now I'm going to go to the next question. A 65-year-old man is found incidentally to have a 2 centimeter cystic mass in the pancreatic head. An MRCP is performed showing the mass in communication with the main pancreatic duct, and the pancreatic duct is 6 millimeter in diameter. An endoscopic sampling of the mass shows the cyst fluid rich in CEA and amylase. The man has no complaints, and his hepatic function panel is unremarkable. What is the most likely diagnosis? So again, I'll give you a couple seconds. Either remember the answer or write it down. And I'll go through the cystic masses. So I think the part of the reason why this is such a difficult topic for a lot of people is because there are so many things to remember, right? Viscosity, amylase, mucin, communication, KRAS. I think the key to successfully remembering and being able to distinguish them is to minimize the number of things you have to know. So after staring at this chart for a long time, I found that it becomes easier if you know that, number one, there are a finite number of things they can ask you about. Part of the fear comes from not knowing, the scope of things they're going to ask about. So I've listed the 4 lesions here, and I'm purposely leaving out the side duct and main duct IPMN because that was in the later part of my presentation. So that's number one. Know that there's limited things that they can ask you about. Number two, if you look at serocystic neoplasm, you'll notice that whatever the criteria is, it's low or negative, right? So viscosity, amylase, everything is low, everything is negative. Now, if you look at IPMN, everything is high or positive. Now, this is a great tool for you to remember, right? So, if any of these criteria is high, it can't possibly be a serocystic neoplasm. Somebody is saying I have an echo in my audio. I'm not sure how to fix that. Let me see if my WebEx is muted. And it is. Okay, I'll keep going for the moment. So like I was saying, everything in IPMN is high. So if any of the criteria is low, then it can't be IPMN. And the third thing to remember, amylase follows the duct. So this is the most important point, I think, in remembering these questions. If you look at the pseudocyst, it communicates with the duct. Therefore, amylase is going to be high if you sample this. Now look at IPMN. It tells you in the name, right? It's intraductal. Therefore, what do you expect the amylase to be? You expect it to be high because amylase go through the duct. And if you look at serocystic and mucinous cystic, they have no communication with the duct, so amylase is low. And lastly, the tumor marker, CEA, is associated with higher chance of malignancy because it is a tumor marker. So IPMN and mucinous cystic are the 2 lesions associated with higher chance of malignancy, and pseudocyst and serocystic are not. Now, let's do these questions again. So it says the lesion does not appear to have direct communication with the pancreatic duct. Now, before you read any further, what do you expect the amylase to be because it doesn't communicate with the duct? You expect it to be low, and it is. Now, that immediately rules out what? IPMN, because you can't be intraductal if you don't communicate with the duct, and pancreatic pseudocyst, because you can't collect pancreatic juice if you don't communicate with the duct, right? Then we look at the CEA level, which is low. So between mucinous and cystic, or serocystic, which one is it? It's the serocystic, right? Because mucinous cystic has a chance of malignancy, therefore it should have high CEA. Now this question, the mass is in communication with the duct, so therefore I bet the amylase is going to be high, and it is. So this rules out 2 things immediately, right? Both serocystic and mucinous cystic, they do not communicate with the duct. And then it says the CEA is rich, so it's either IPMN or pseudocyst. Pseudocyst shouldn't have any CEA, so the answer is IPMN. So all of these effects were done using just wipe for pretty much everything, and that was using just the text. And now I'll show you what you can do with using wipe on boxes. So let's draw some boxes. Now I'm starting to hear the echo as well. Is anyone's WebEx not muted, I wonder? Please check. Mine is muted. Okay. I'm not sure how to fix the echo. Somebody's WebEx must be not muted. Dr. Edwards, I see your mic is turned on WebEx. Sorry for calling you out. Brian Nasca, your mic is not muted on WebEx. Dr. Edwards, I see your mic is turned on WebEx. Sorry for calling you out. Brian Nasca, your mic is not muted. I'll send out the link again. Okay. Woy, your audio is not muted as well. Okay, I'll keep going for the moment. I apologize that this is an issue. So I'll show you what we can do with drawing boxes and using animations. And by drawing boxes on top of another box, we can represent percentages like so. So the way I did this was each of the tall boxes are 2 inches. So to represent 75%, I made the 75% box a 1.5 inch. And to represent 50%, I drew it as 1 inch, and so on and so forth. And last thing I'll show you, I'll talk about exit animations. Just like how you set the animations when the object enters the slide, you can set up how they exit the slide. So if you look at these 2 bars, you think that the bar on the left is just 1 bar. But I've actually made it look like that with multiple boxes with same color. And then by making each one of them disappear by exit wiping down, I can make it look like the bar graph is shrinking. And another creative way you can create the same effect is if you make boxes of the same color as the background appear. So if you wipe down the same color box as the background, you can create an illusion that the bar graph is disappearing. So I'll show you how I use this on my presentation. So going back to my journal club slide 1, transitioning to slide 2, rupture AAA has been shown to have anywhere between 70 to 85% 30-day mortality rate with open repairs. Initially, though, going as far back as 1994 for using EVARs for rupture AAAs, the mortality wasn't different compared to open repairs. But more recent studies started to show that there is a modest but significant improvement down to about 50% mortality with EVAR. And even more recently, with many centers using the standard EVAR protocols for ruptured AAAs, the mortality goes down as low as 20 to 30%. Now, I'll show you how I did this. So I did that by just exit wiping everything to the left, and then entering the next picture by wiping to the other side. And then the percentage bars appear with wiping up, and then more bars appear by wiping up. And then I give the illusion of the percentage bar disappearing or shrinking by using wiping down. So by using some boxes and some wiping animations, I turned a slide that could have looked like this, which ultimately is just talking about mortality for open and EVAR, into something that looks like this. And the last set of stuff I will show you induces a lot of headache to make, warning. And I generally don't recommend you try to be super fancy unless you have some serious obsessive compulsive tendencies like myself, or if you really need to impress someone, because it involves a lot of try and error, making small changes and checking it in presentation mode again and again. So I'll show you the end results here first, and then give you some tools to get started in case some of you would like to try. And I think when used right, it can really help to simplify complex subjects for the audience, especially the second example that I'll be talking about. So this is a slide I used for a visiting speaker case presentation last year in February. And it's about describing the steps of LAR. And I took notes from the Clinical Scenarios book and also one of the op notes of Dr. Valerian when I was making this. So LAR, everybody does it differently, but the way it's presented here, first we mobilize the sigmoid colon off of the retroperitoneum and identify the left iliac and ureter along the way. And then we isolate and divide the superior rectal / IMA at its takeoff. And then you raise the mesentery of the sigmoid like a curtain, and then bluntly separate it off the retroperitoneum through avascular plane. And then you divide the lateral attachments along the white line of Tolt and mobilize the splenic flexure if you have to. And then you perform the total mesorectal excision by entering the avascular areolar plane between the visceral and parietal layers of the endopelvic fascia. And along the way, you identify the location of the tumor during the dissection and decide where to fire the stapler. And then you decide where to fire the stapler approximately. The specimen goes out, and you make the colorectal anastomosis using the EA stapler and do a leak test. The next example I'll show you is a slide I used for my colorectal conference presentation in August. It was just on anorectal malignancies. And here's a slide describing the anatomy, which can be pretty complex. So we have the internal and external sphincter muscles highlighted in green. And these two black lines, the upper one is the dentate line, and the lower line is between the internal and external sphincters, aka the intersphincteric groove, which also happens to be known as the anal verge. And then they divide this area into three different regions based on histology, columnar, and the keratinized and non-keratinized squamous epithelium. First, the anatomic anal canal, as you can see, is from the anal verge to the dentate line, which is usually about 1 to 1.5 centimeters in length. Now, because that's not complicated enough, there is a surgical definition of the anal canal, which goes from the anal verge to this line, which is another 1 to 1.5 centimeters in length. So the surgical anal canal takes into account the surrounding muscles that are critical to performing surgeries like LARs or APRs or fasciotomies. The red circle here is the anorectal ring, and it's where the superior fibers of the internal and external sphincters and the puborectalis muscle meet. And you can see the sagittal view here, the blue sling is the anorectal ring. So for the rest of the presentation, we refer to the surgical anal canal. Now, this area within 5 centimeter radius from the anal verge is defined as the anal margin, and everything outside of the anal margin is skin, and tumors there, therefore, are treated as skin cancers. And these are the tumors that are present in these different locations. And I went ahead and talked about each one of the tumors divided up by the locations. So I'll show you some of the tips that I use to make those slides. So to have stuff move around on your slide, you can draw a box and then click Add Animation. And there's an animation command called Motion Path. And under Motion Path, you can choose a line for the box to make the box do this. You can also change the direction and the distance where the object will travel. If you choose a custom path, you can actually make the object go anywhere you want. And you can change the time it takes for the animation to take place to decide how fast the animation to be. Now, applying this, I wanted the text and the arrow to move to the left so I can make room for the types of tumor to show up. So I grouped the text and the arrow together and set an animation to move to the left, like so. And the other thing I'll show you is you can group the pictures together so they look like one picture, and then move them away from each other to give the illusion that I am separating them. So, you know, all these pictures look like one piece, but they're actually two separate pieces of picture, and I put them together to make it look like they are one complete picture, and then I just set motion path so that they move away when I click the mouse. And lastly, to coordinate things so they move when you want them to, go to animation pane and you can set the timing. So for example, I can set start on click, and boxes will move only when I click. Or if you set it so that the next box moves when the previous animation is finished, you can set it so that they move automatically. Or you can set them all to move all at the same time. So that's all I'm going to talk about with regards to making slides. Thanks for bearing with me. I know some of this is technical and it doesn't apply to all of you, but I mainly had the residents in mind when I made this PowerPoint. So I wanted to sort of apply what I talked about and kind of show you what I really think is interesting as an example presentation. So I was recently applying for the board exam, and they had me list every rotation I've been on since my intern year in a chronological order. And they had me print out my case numbers by year and everything. And it was really interesting to see all that collectively. Now, the $1,800 they had me pay wasn't very interesting, but anyway. So to start off with, rather than going through every single one of my rotations since intern year, which would be excruciatingly uninteresting, I thought it would be interesting to talk about the sort of evolution of my interest in various specialties over the years. So especially for younger residents in the audience who are wondering what they should do when they grow up, I think the lessons I learned were keep an open mind, and don't be afraid to accept a challenging opportunity, and don't be afraid to change your mind. So I came to residency wanting to do hepatobiliary surgery. As a medical student, I had rotated on surgical oncology, MIS, SICU, and then surgical oncology again as an AI. And I like a lot of other medical students, I wanted to do like big cases like Whipple and liver surgeries. At the time in my med school, there were 4 surgeon attendings, and they did a lot of Whipples, and I really idolized them. But I still had a pretty open mind, I would say, about a lot of other specialties. Notice pediatric surgery, though. It's not that I wasn't interested in the specialty, because I surprisingly ended up loving pediatrics as a med school rotation, and especially the NICU. It was just that I heard from everyone around me over and over in medical school that I have to have my CV plated in gold with 5,000 publications and mind-blowing test scores. So I heard that and I was like, that's not me. So I kind of put a mental hold there while I rotated through a lot of other specialties that I had not rotated before. During my second year, I generally had an increase in interest in pretty much all the specialties except for thoracic because of certain somebody, the he who must not be named. Actually, there were 2 of them. One of them is now in Temple, but Anyway, at the same time, my interest in pediatrics continued to grow. Although I wouldn't say interest, I think enough interest was there already, but it was like my doubt about whether I stood a chance started to melt a little bit as I did projects with Dr. White and Dr. Renaud. And I started going to, I went to my first national meeting to present something I did with Dr. White. And I met my PI, lab PI at CHOP. And sort of things seemed like maybe I could do it. So by the time third year came around, so at the end of my second year, I had already found a research lab that I was going to be at for 2 years after my third year. I had written a grant proposal for an ACS research scholarship because my PI made me do it as a test to see if I could be trusted. So on one hand, I guess you could say that I took a big risk. But on the other hand, you could say that I just kept opening open doors out of curiosity, like, oh, I wonder where next door will lead to. So I just kept opening, and the doors kept opening. So, that's how I ended up kind of committing to research. And I thought, even if I don't end up going into pediatric surgery, the 2 years of research will help me in the long run. Also noticed that by the end of third year, I was just exhausted and just sick of traumas and emergencies. I've had enough excitement. I don't want it. I want to do my scheduled cases and go home. But recently, I started to learn that life as a surgery attending is pretty different from life as a resident. So it's not the most accurate way to rule things out solely based on the residency experience for each of the specialties, because I did start to like trauma a lot more as a PGY 4 and 5. And then fourth year came around, and I would say colorectal surgery was my personal rotation of the year. I was leading the resident team, seeing patients in clinic, scrubbing in on the patients that I saw in clinic, talking to patients and family. And I really felt like I was actually the leader of the residents. And I was taking responsibility for a lot of the things that happened on the service, the good and bad. And I really felt like my words to the patients carried weight. Like when I sat down with a 14-year-old girl with Crohn's who ended up with a colostomy, totally healthy previously, and I had to put a Malacot drain in her rectal stump to see if she had any pus there. Or that crazy patient who was, being mean to nurses and residents and everybody around them, and I had to talk to her. Things like that. Really, a lot of memorable patient interactions. And I think my biggest advice for the upcoming PGY4s is to get into the mindset of thinking as if you are the attending. Get into every patient encounter, interaction with the team, and in the OR. Just imagine yourself as the attending and the only surgeon there, and treat every scenario, every little scenario, as a glimpse or a peek into your future self as an attending. And I think that will make your fourth year experience a very memorable and valuable, as I'll talk about more things later in a couple slides. Now, I did a match into pediatrics. That's what ended up happening. And, the main reason I wanted to do peds was, and it was because I thought, well, I still think the preemies and the newborns are the most precious thing on earth. I still think that. The preemies are so precious. And also because I invested 2 years of my life into fetal research. But, that's a pretty single-dimensional reason. And there are a lot of other things that go into the consideration of choosing a specialty, like how much exposure have I actually had to this field? I rotated on colorectal, as a PGY 1, 2, 4, and 5, and do I like doing things that the specialty does every day? Do I like colonoscopies? Do I like small anorectal cases or big abdominal cases, pelvic cases? Which specialty attendings do I most want to be like? What kind of day-to-day life do I want to live? In which specialty have I had the most memorable patients? And, considering all these multi-dimensional factors, it was sort of actually an easy choice for me to commit to colorectal surgery after my first match didn't go the way I wanted. But Actually, now I'm thankful um, that I ended up choosing colorectal, and the specialty ended up choosing me as well. So I'm very happy about it. And during my 5th year, I would say my personal rotation of the year this year goes to G1. I just had a blast with Dr. Nigam. He said it was the busiest January and February he's ever had, and just my memories with him in the OR doing whipples and pustos that he had not done in several years. There are a couple other things that he hadn't done in several years, and it was just a blast. So yeah. And I wanted to go over, so this is kind of my over the years series, so that was my specialty interest over the years. My case number over the years, you can see, I thought it was a pretty interesting trend. My senioritis is showing pretty badly here. PGY5 case almost slightly over PGY2. But I think I operated a lot more as a PGY2 maybe than other people. I don't know. Maybe I had lazy chiefs. They made me do a lot of breast case, as I'll show you later, and a lot of thyroids too. And if you look at my PGY3 year, oh boy, that's a dark year. I feel really bad for all the PGY3s. Feel bad for the PGY2s that are going to be PGY3s. But do not despair. The current PGY3s, it's almost over, right? You have almost just a month or two left. And you can look forward to the PGY4 year where you literally operate like a fiend. Like, I was very surprised to see how many cases I ended up doing as a PGY4. Just as a reference, I ended up doing a total of 1,410 cases, 1,031 major cases, and 381 other miscellaneous cases. I don't know what my other co-chiefs ended up doing, but it's interesting. And I think this is the most interesting graph out of all of my slides today. The distribution of cases over the years is very interesting. So breast and endocrine cases, so many as a PGY2. I think South Clinical just really, at the time, must have been booming or something. So many breast cases and thyroid, parathyroid. If you look at predominantly PGY4 cases, thoracic and vascular, and the specialty of my interest, colorectal and anorectal and colonoscopy cases. So I contacted Dr. Richter through Dr. Lee and Rob, and I was able to squeeze in a lot of colonoscopies just before the COVID hit, actually, during my chief rotation. So thankful for that experience. If you look at API and colis, I think I'm pretty comfortable. I've already done cases on trauma with another resident, either standing there with her arms crossed, or just not scrubbing at all, from skin to skin, leading another resident through. I feel pretty comfortable doing like colis and APIs. And surprisingly, hernias, I didn't really do much as a PGY5, it turns out. So maybe when opportunities come in my remaining time, I could do some more hernias, because I think the groin anatomy is one of the most complex things I just had to review over and over again. And as a side note, if anyone is interested in seeing a graph like this for yourself, just let me know. It's actually really easy to make. Just go to ACGME case log and go to report by year. And if you send me the PDF, I can make a graph like this for you, so you can see what you want to focus on in your next year and things like that. So it's just very easy to, if you're interested, just let me know. And lastly, I wanted to talk about my app site, not because I'm a rock star, but as you can see, I sucked pretty badly for the majority of my resident career. But I do think I learned one thing over these painful memories. And if you look at my first 3 years, even though I wasn't doing worse, absolute percentage correct questions wise, my percentile just kept dropping and dropping, and I just was so devastated. And usually the PGY3 app site is the most important one, because a lot of specialty fellowships application begin like September of your 4th year, so the last app site score they will see is the PGY3 year. So I told myself, okay, I'm going to study really hard doing research, try to make it up. I have 2 years to study. They say you only need one good score, so I'll, show improvement this year. So I did like, TrueLearn and two other question banks, up close to like 2,000 questions. I made my own notes on all the subjects. I listened to a podcast about AppSci, did everything I could. And my score during research was still pretty tear-jerking. I mean, um, I guess at this point, I kind of knew that like not very many pediatric program will be interested in me. PGY 4-year, kind of the last opportunity to prove my worth. Colorectal application, if I don't end up matching in pediatrics, is due like July of my chief year. So if I do well here, maybe I'll be good, right? I hear score is good, so I do all the score questions. My co-chiefs will tell you, like, I was constantly doing score questions. I think I did close to 1,500 questions. I think I did everything except for fellowship level score questions. And the result? The same old score, kind of even worse. Like at this point, like I'm pulling my hair out. I give up. Like this test sucks, and I accept that I am consistently dumber than 60 to 70% of all surgery residents out there. And then during my chief year, this happened, and I'm like, what? Like what happened there? Like I don't understand. Like it's not like I did drastically better than all the other years, but the percentile went up. So I'm not sure what happened, but I do know that the percentile this year was kind of statistically significant, even though I didn't do any stats. But like I said, my research year, I did a lot of questions, made my own notes. My PGY 4 year, I tried to do all the score questions. And my PGY 5 year, what I did different was using flashcards. And I know it can sound really dumb, and somebody can be like, you haven't used flashcards all this time, but it is true. I think my biggest problem in studying was that I was spread out too thin all the time. I think I was subconsciously trying to remember everything, and the process actually not deeply remembering the important things. So this year, I really, every question I got wrong, I put it in my flashcard and try to go over my flashcards whenever I get a break. And that really helped me, I think, remember things. And also, maybe subconsciously, I'm studying a little better for board studying. I don't know. But flashcards, honestly, is the only thing I can think of that I did differently that improved my score this year. And last but not least, because I had the pleasure of making the call schedule for everyone throughout the year, I had the chance to look over the call count summary at the end of the year. And these are the numbers, excluding nights, excluding weekend rounding, excluding the outside rotation like the VA, Saratoga, St. Peter's. So some of these guys had to take more than 224s and 12 during 1 month. And at the end, as you can see, almost everyone ended up having almost the same number of calls for each class. Again, the PGY3s suffer because they do the hardest job in the hospital, the job that nobody wants to do, and they take the most number of calls. They're the most exhausted. So we thank you, PGY3s. You're almost there. Just a couple months left to be PGY4 and start operating again. PGY2s, your tunnel is coming, but there is a light at the end of the tunnel. You will come out with better judgment, stronger character. So just I thank everyone for putting up with me, for the schedule and everything. And I'd just like to thank all the attendings for just guiding me and helping me become who I am as a surgeon today. All of the attendings, directly and indirectly. Just thank you so much for my education here at Albany Med. I couldn't be happier. So yeah, that is the end of my presentation. Sorry for the technical delays and hiccups, but I think overall, besides that one disconnect, I think things went okay. So we can go back to WebEx if you have any comments to make. So, or you can leave comments on the live chat. So that is all I have. Thank you.
do differently, I guess, having read over the last 7 years?
Things I would do differently. I think I would start using flashcards from PGY one. I mean, I don't know. I just feel like the commitment to deep memory, like knowing. I think part of it is knowing what's important to know. I think as PGY five, like some of the details, you think you know the boards is gonna think it's important for me to know. So I guess I subconsciously sort of categorize things better in terms of what to commit to memory. And I think I wonder if my AppSci score was better, things would have turned out different. Not that I have any regrets or anything, but I just think it's a very interesting test, and very small difference makes a big difference in the percentile. So another thing I would do differently is I don't know, not be as lazy as a chief. Operate more, do as many things. But I don't know. To me, this year has been sort of a balance between trying to pretend like I'm an attending and also trying to save myself enough time to study for boards so I can pass. So, yeah.
Yeah.
Anyone else with comments? No, thank you very much. Wonder if Dr. Zaman is logging back on to have any concluding remarks. But I think that's it for this morning. So.
She may not be coming on, I guess. But thank you, Nick, so much. This was really good. I was blaming YouTube, but I was just kidding.
And like I said, I will upload the PowerPoint so people can download it. Feel free to copy everything, copy all the animations, use it to your advantage, use for your future presentations. So thanks, everyone.
Helpful. It's a really important skill for everyone, frankly, because PowerPoint presentations can be such trash, but they can also be so good, and they're really important. So thank you for talking about it.
Of course, thank you.
For tonight, for the oral boards at 4 o'clock, please call in with video. We want to make this as realistic as possible. So I know you don't like it, but it's going to be much more functional and much more productive if you guys can call in with video. So if you don't want to do video for M&M, do whatever you want, but then call back at the 4 o'clock hour with your video on. All right, everybody, have a good day, unless there are any other comments. All right, bye.